And then some folks maybe have just joined us at lunch, so just kind of want to do a little recap of the morning and share a little bit about Healthy Chicago 2025. So, as I said, hello and welcome. This is our Healthy Chicago 2025 Symposium and Healthy Chicago Equity Zones Showcase. So this morning you have here from our Deputy Manager, Deputy Commissioner, Megan Cunningham, and Denise Turner, our Director of Health Equity and Strategic Partnerships, about all the wonderful work that has happened since we kind of came out with this plan in 2020 and where the work is to go before 2025. And then you're going to hear from a panel of our Healthy Chicago Equity Zone, regional leads, and community leads. I hope you guys really enjoyed that. They're the most amazing people to work with. And so that kind of brings us to this afternoon where we get to go a little bit deeper on some of what you heard this morning. So, kind of hearing about the framework that really underpins what Healthy Chicago 2025 is and what drives our decisions. So I'm going to pass it over to our amazing epidemiologists, and I'll let them introduce themselves.
Hi everyone, I'm Emma Borland. I'm an epidemiologist within the Chronic Disease Prevention and Health Promotion Program at CDPH.
Hi everybody, good to see you. Glad you all came out. I'm Brianna Pickens, and I'm an epidemiologist in the Office of Epidemiology.
Right, so I'm going to be presenting first on changes in Chicago's life expectancy and population since 2010. Can we go to the first actual slide?
Can you hold the mic a little closer? It's kind of getting right now.
We tested it, but there's no test like Okay, so we heard a little bit about Healthy Chicago 2.0 leading into Healthy Chicago 2025 as a program downstairs. Is this one better? Let's capture. That's not bad. Maybe that's Okay, I didn't want to project into the microphone. Okay, so in data terms, our transition from Healthy Chicago 2.0 to Healthy Chicago 2025 means that we still care about all of those Healthy Chicago 2.0 health indicators that are incredibly detailed. We have many that Brianna will go into. And in Healthy Chicago 2025, we added a new indicator, and that's our focus on the racial life expectancy gap in Chicago. So we expect to have new information for you about the life expectancy gap later this year. We're excited to share it and provide the full context for you about how life expectancy has changed for all Chicagoans. So what does life expectancy mean, and why are we so focused on it here at CDPH? Life expectancy is the average age that a person could expect to live in our city. It takes into account the fact that at different ages as we go through our lives, we have different risks of death. And it takes into account all of those risks of death, averages them to find the age that an average person in our city could expect to live, given the health conditions that are prevailing in the population right now. So it uses the specific risk of dying for every age group, and it's especially influenced, as you might imagine, by deaths in younger people. Infants in particular are very vulnerable, and then our vulnerability to dying gets lower as we get older, and then creeps back up in our later adult years. So when we think about like deaths in children, they're especially influential, or deaths in young adults, very influential. Life expectancy takes account of every known death in Chicagoans. So you probably know we have things like survey data, focus group data that we also use at the health department that use just a sample of Chicagoans. That's not the case for life expectancy. We actually take into account every known death in a Chicagoan during the time period that we're reporting out to you. It's also one of the reasons it takes a little while to get to. The causes of the gap are common for all Chicagoans. So Megan presented a little information this morning about what we believe are the major drivers of the life expectancy gap. For something to be an important driver of the gap, it has to be a really common cause of death in general. And it also has to be something where one group is unfairly exposed to that cause of death more than another group. So the causes of the gap that you saw, things like heart disease, homicide, they're very common. Unfortunately, heart disease is the #1 killer of everybody, but when something contributes to the life expectancy gap, it also means that Black Chicagoans are more at risk than white Chicagoans of dying of that cause, and they're probably being killed at younger ages. So even if like a Black and white Chicagoan or neighbors ultimately were to both die of heart disease, the reason for the gap is that that Black neighbor was probably not getting to live as long of a life overall. And what we've seen in the analyses we've done of life expectancy so far, we've seen that Black Chicagoans are overall less protected when it comes to any cause of death. That's why the gap is so large and why it's so critical that we close it. So later this year, we will have updates on Chicago's life expectancy data. They're going to take into account new mortality data that we got from the state of Illinois for all of 2021. So we'll be able to update you on 2 years of pandemic impacts on the life expectancy of Chicagoans. We also have new 2020 census data. So that did not become available to us in the level of detail we needed to calculate life expectancy until May of this year. So we've been processing that, ensuring that it's accurate enough to use for our public health statistics, and we're almost ready to move forward. And finally, our life expectancy analysis will take into account subject matter expertise of epidemiologists from all across the department who are embedded in our programs and who are experts on the specific populations and causes of death that we plan to give you more information about.
Go to the next slide.
Okay. So what we know about changes in Chicago's population so far, our total population is about 2.7 million. It's been around that since 1990. So you might hear that it went a little up or a little down, but it's been kind of bouncing around between 2.6 and 2.8 million for the last few censuses. Our population is still predominantly non-Latinx white, non-Latinx Black, and Latinx, and about 30% in each group. The percentage of our population that is Asian increased. So these are the changes in population across all Chicagoans and the age of the population. Our population aged overall, so we expect to see effects of that in our updated life expectancy and mortality data, and to see that the health needs of older adults are going to become more prominent when we think about the health needs of all Chicagoans. And this kind of pattern with, where it's kind of wavy, with fewer children, more older adults, and kind of some changes that balance out in those middle adult ages is very similar to what we saw in the country overall. Go to the next one. Changes for the ages of Black Chicagoans were very similar to changes in the population of Chicago overall. So reductions in the youngest ages, increases in the oldest ages, and kind of some trade-offs in age in between. The Black population of Chicago did decrease since 2010, but it changed. Beyond that, it changed in a similar pattern to Chicago overall. Go next. The same is true for non-Latinx white Chicagoans. More or less a reduction in the youngest ages and an increase in the oldest ages, and kind of some flux in the middle. It's a very different picture when we look at Latinx Chicagoans. So I think Megan mentioned this morning. We do expect to see these changes in the population of Latinx Chicagoans affect our estimates of life expectancy. And one of the things that we're hoping to bring to you this fall is some context for the changing population and health needs of Latinx Chicagoans. So the Latinx Chicago population is aging overall, and with decreases in the population of children and increases in the population of adults over 40. What we're seeing in our preliminary analyses is that we expect to revise the life expectancy of Latinx Chicagoans upwards from what we previously reported. That's great news. We want to be sure of it before we share it in detail, and we want to be clear that that doesn't mean like everything's great. We just had a pandemic, and we want to put that in its proper context to share the health needs of the Latinx population in particular, as it includes more older adults. The next one. And finally, we're seeing something quite different among Asian Chicagoans. We saw increases in every single age group. And that's consistent with what we saw, that the Asian population in Chicago increased overall. So we're hoping to be able to bring more detailed statistics to you about Asian populations in Chicago. And the fact that this population increased will obviously increase the importance of that, but also our ability to share reliable information with you. So, what is coming? We will have updates on the size of the gap in life expectancy between Black and white Chicagoans. We'll share new analyses with you that we haven't shared much publicly before, where we're able to quantify the number of years added to the gap by different causes of death. So we'll be able to share with you even more detail about the top health problems and causes of death that are contributing to unfair reductions in life expectancy of Black Chicagoans in particular. And we also expect to be able to share the top causes of death that are contributing to changes in life expectancy within every major racial or ethnic group and for Chicago overall. So we will have new life expectancy statistics for every group, even though the top line indicator for Healthy Chicago 2025 is that racial life expectancy gap. Everyone experienced pandemic impacts. Everyone experienced changes in their life expectancy in the last 2 years, and we'll be updating all of that for everybody. All right, next I'm going to hand it over to Brianna Pickens to update us on Healthy Chicago 2.0 indicators that we've been tracking for quite some time. So even though we don't have updated life expectancy, we do have a lot of other updates on Chicagoans' health that we can share with you today.
For the transition. So this portion of the presentation is going to be more of a data brief, so we're going to talk numbers. So as Megan Cunningham and Jenny Turner said earlier in the keynote, the development of the Healthy Chicago plan included feedback from community stakeholders and residents, so many, like hundreds of them. So that's truly the way that we see progress in our health data, is through collaboration. Next slide, please. So together, the stakeholders and the residents came up with 65 indicators that monitor trends, and they also address the racial life expectancy gap. And so these indicators are organized into categories that we sometimes call pillars, and there are 8 of them. The 8 pillars are 1, overarching, 2, access to care, 3, built environment, economic development and housing, 4, behavioral health, 5, child and adolescent health, 6, chronic disease, 7, infectious disease, and 8, violence prevention. So we're going to get deeper into all of those. And for this presentation today, I've included 47 of the 65 indicators, selecting the ones that had the most complete and reliable data. So we'll go over those. There are too many to go over, so we have to pick and parse down. The 65 indicators are all actionable, which means we can intervene on them. And we monitor them so that we can communicate where we need to make improvements. For each indicator, we track baseline, target, and we also track the latest data. We track baseline data, which is the latest data that we had at the time that we developed the Healthy Chicago 2.0 plan. The baseline year is not always the same for every indicator, so the year can range from 2011 to 2015. And we track the baseline data to understand if we're meeting our goals. And so then that takes us into target data. So target data is the goal where we want it to be by 2020. And the latest data is the most available data that we have at the present time, which is anywhere from 2020 to 2022. And we're really proud of the fact that we have as recent data as 2022. It's not that simple for us to just get data and then boom, we can share it out. There's a process. So good data has to be obtained, which can be a lengthy process in itself. And then after that, we take a lot of time and effort to clean and analyze the data. And then from there, it takes much more time to put the data on a dashboard or to make a report. So these citywide estimates that we're going to talk about today are, for the overall Chicago rate or count or whatever whatever the unit is. But we're going to pay very close attention to priority populations as the plan is outlined. Next slide, please. So during the pandemic in 2020, CDPH released the Healthy Chicago 2025, which is a follow-up to the Healthy Chicago 2.0 plan. And the 2025 plan recognizes that there are social and institutional barriers to the racial life expectancy gap. So the takeaway that I just want to make is that the indicators did not change when the plan got updated. We want to track the same indicators so that we can see progress that we're making over time. Next slide, please. So let's talk a little bit about how to read this table from left to right. There are 4 indicators in this table. The priority population is citywide, which just means that there was not a particular group of people that we were interested in monitoring for the indicator. And also, we have our baseline data, which again is where we were when we first developed the plan. The target data, which is where we want it to be. And then the latest data, which is where we are now. And using the most, so the latest data uses the most up-to-date data, as I mentioned before. And the result is our conclusion of the indicator's progress from our goal. And in the interest of time, I won't go over all the indicators that are in the presentation. Instead, I'll mostly focus on the successes that we've seen in the data. But if there are any questions about indicators that I don't cover, there will be a Q&A session at the end. So feel free to park on your questions. The overall health status rate was reported as good to excellent health, which increased by 7%, which meant that we met the goal. We actually met it above and beyond, which is really great. And the overall health status data comes from CDPH's Healthy Chicago survey, which is administered annually. And we got responses from a few thousand people. It was a random sample, and they gave us data through the web or surveys that we had mailed out to them. And with that, once we got the data back, we analyzed it and we statistically made adjustments so that that random sample could reflect the entire Chicago population. CDPH is working to better understand the increases and the decreases that we see in the data. So, are we seeing increased data due to the fact that people were more resilient during the pandemic? So, although, we talk a lot about health during the pandemic and a lot of people got sick, overall, the health status rate increased. So, as we see this data, we're trying to better understand, why that would be. Or would it be due to something like, because people got more, they sought out more care? Or could it be the fact that, you know, CDPH and CPO programs are working tirelessly to make sure that we see good rates like this? Or maybe it could be a combination of all of the things. Next slide, please. Okay, so this is the access to care category, which has 4 indicators. 75% of them are meeting their goal above and beyond. Primary care provider, uninsured, and dental care ED visit rates come from the Healthy Chicago Survey, the Census American Community Survey, and the Illinois Department of Public Health's hospital discharge data. The Healthy Chicago 2.0 plan identified the Latinx subgroup as a priority population for 2 of these indicators. These citywide estimates increased by 11%, decreased by 10%, and decreased by 45% respectively. But there are still disparities in the Latinx population. For example, the Latinx adults are uninsured at least twice more than the rate of other racial and ethnic groups. Next slide, please. This is the built environment, economic development, and housing category. 1 of 3 indicators in this category are exceeding the goal. This is the child lead poisoning rate, which decreased by 4%. These data come from CDPH's lead poisoning prevention program. Successful programs like this are something that we need to consider when we are looking at successful declining rates. Next slide, please. This is the behavioral health category. There are a total of 7 indicators in this category, 3 of which are on the next slide. And although the behavioral health treatment is a goal that's not met yet, I think that we should expect data to increase, partly due to the fact that there has been a lot of expansion in city-funded mental health services in all of the 77 community areas. And also, there has been integration of mental health services in the 911 system. The overall city rate for youth suicide attempts has exceeded the 2020 goal, and the rate has decreased by 4% in 8 years. These data come from the Chicago Public Schools Youth Risk Behavioral Surveillance System, which is also known as the YRBS. And we're really happy about this progress, as suicide is a national, high-profile public health issue. Okay, next slide, please. Opioid-related overdoses is another big category indicator, I should say. This data comes from Chicago Fire Department's EMS data. And despite the fact that we have not yet met the goal, we're really optimistic that we will see a significant decline in responses to overdoses, because CDPH's efforts in harm reduction has been able to allow more people access to Narcan in all public libraries. Chicago public libraries. And also, in addition to that, there has been a lot of effort to get Narcan into public health vending machines. The rate of behavioral health hospitalizations has decreased by 23% over 6 years, and that data comes from IDPH's hospital discharge data. Next slide, please. And the child and adolescent health category only has these 2 indicators, which have both exceeded their goal. The infant mortality data comes from the Illinois Department of Public Health vital records. The mortality rate has decreased by 44% over 7 years. And as we monitor the infant mortality trend, we expect to see continued decrease, partly due to CDPH's Family Connects program, where free at-home nurse visits are offered for newborns and their families. The teen birth rate also comes from vital records. The rate decreased by 75% over 7 years, when the Healthy Chicago 2.0 plan had a goal to decrease this rate by 11%. So that's huge. It's like barely believable. Next slide, please. This is the chronic disease category, which has 17 indicators, and it has the largest number of indicators than any other category. And this number is probably proportional to the impact of chronic disease. It's probably proportional to the fact that chronic disease has the largest impact on the racial life expectancy gap. Chronic disease makes up about half of the gap between the Black and white Chicagoans. Adult fruit and vegetable consumption data comes from the Healthy Chicago survey, and that rate has increased by 11%. The youth soda consumption comes from the YRBS, and the rate decreased by 10%. And we expect to see many food equity and policy efforts continue across the city. So we'll probably keep seeing progress in these areas. The youth and adult smoking are measured by the YRBS and the Healthy Chicago survey. The rates decreased by 9% and 7% respectively. Next slide, please. Colorectal cancer screening rates have increased by 8%, but remain low in those who are living in poverty and those who are among the working poor group. And for the sake of time, I think we can move on to the next slide. Just to note here that we did not originally track cancer mortality and heart disease mortality in the original Healthy Chicago plan. So that's why you see no target estimate there. But as we know, these are really important issues. Within chronic disease, we want to continue to monitor. And then infectious disease, there are 4 indicators in this category. And I won't go into detail about these indicators, but just know that we are working towards making progress. And then lastly, we have violence, which has 6 indicators, and 50% of them have met the goal of beyond. There's been a 30% decrease in criminal sexual assault, an 11% decrease in school fights, and a 19% decrease in bullying. And in general, there remains a disparity in the LGBT and non-Hispanic Black communities, that's a mouthful, that are more likely to experience violence. So we, make them a priority population. And this is a great example of being able to monitor Chicago's progress, because data that is external to CDPH has been made available to us. These data come from vital statistic records from IDPH, the Chicago Police Department's crime data, and the YRBS. And this data is super helpful we will continue to advocate for new data sources. And also, data access also, again, makes us be able to target priority populations who need prevention programs, like violence prevention. Okay, next slide. And so I just want to leave you all with a few remarks that we're really happy to be able to see this progress that we've made so far, particularly when indicators have met their goal above and beyond. However, in those instances, it is not uncommon to see some disparities still exist within our priority populations. So we just want to not forget about that. And we're still trying to understand them, and we plan to release an interim report for the Healthy Chicago 2.0 later this year. So stay tuned for that. Next one. And CDPH and the city are still committed to investing and working to change policies that are fair for all Chicagoans. So to achieve this, us epidemiologists at CDPH will continue to look for new data sources, monitor trends, and communicate with CDPH, the city, and all of the CBOs, and update, and communicate and continue to collaborate. Okay, and if you're looking for more data on these indicators, you can visit chicagohealthatlas.org. Many of you may already be familiar with this, and I'm a little biased, but this is the premier data dashboard for a lot of health indicators that we track in Chicago. It's user-friendly, and it has the ability for you to be able to customize the data that you're interested in, even to the point where you can see maps and graphs for specific priority populations and other disparities. And so now I'm going to turn it back over to Emma. She's going to talk about where you can find more data.
If you want more data that you can look at in your own time, we have many reports that have come out recently. And the great thing about these is they take into account the subject matter expertise of entire programs, or sometimes CDPH employees across programs, and provide the context to that data that you may be looking for with some of these special populations or health problems. So we have the Health Equity and All Policies System Change Collaborative Reports related to the health needs of people who are unhoused, Childhood-Led Poisoning Prevention Data Report, Mental Health Services in Every Neighborhood, Chicago Health Equity Zones one-pager, if you're ever looking for like a quick, easy piece of information to give people about what this amazing program is. The relation of neighborhood racial and income polarity to preterm birth rates in Chicago, Treat Equity Working Group, and the 2021 State of Health for Blacks in Chicago. Next slide. We have more reports coming for you. Many of us are collaborating on a State of Health for Latinos, Latinas, and Latina people in Chicago report that will take account of historical data on the importance of Latinx communities to Chicago, how they've changed over time, and what their health needs are today. That will take into account our new information about life expectancy and mortality, our survey data, and hopefully context from community groups as well. Neighborhood conditions for people with disabilities in Chicago is coming, and so is an interim report on Health in Chicago 2025 that will include the updated data that I alluded to on life expectancy gap and related health indicators. So where can you find data? Go to the Chicago Health Atlas. It's so good, and it's been updated this year actually, so if you've not tried it lately, I highly recommend it. You can, if you open, there's like a menu on the left, you can see all of the Healthy Chicago indicators for yourself. We have the mapping features. If you ever wanted to make a map of a health condition or population in Chicago for your own reports and presentations, the tools for that have only gotten better and better. And the same thing for graphs or charts of health conditions that you or your organization may be interested in. I highly recommend checking it out if you haven't been in a while. We have other dashboards as well, the care data dashboard, the wastewater data dashboard. We still have a COVID dashboard and an MPOX data dashboard. And if you still don't see the data that you need, we have a data request form as well. If you use the data request form, you'll be connected to a CDPH epidemiologist who works in the topic area that you choose and will help you figure out, just because something isn't on the atlas doesn't mean that we don't have it. And if we don't have it, we may know who has that data and can help you out instead. The data request form, I'll say that Atlas is not the only CDPH site that has improved this year. Our main website got better too. So if you go to the CDPH front page, there's literally like a data and reports box with a direct link to that data request form. So thank you all for your attention and your interest in Chicago's health data. I think we're open for questions.
Do we have any questions from the audience? We can go back to any slides. Yeah, we'll step up.
I'm loud, so. I think that as one of the individuals working to support the efforts that the city and the health department does, to see these numbers is a little bit overwhelming. Like I was just texting my sister, like I could just cry when you realize the harsh realities that these racial drivers play, the role that they play in who lives and who doesn't live, or how one will person live compared to how long somebody doesn't live. And I guess I'm interested in knowing like what real results-driven efforts outside of like the community work that we see, at least that I'm a part of. Like I don't know, like how does this work across not just, and I think somebody mentioned this downstairs, not just the city of Chicago, but across all city agencies as well as across government, right? So county. You talk about all these drivers, so like prison. What determines if a person goes to prison or not? If their race is driving that. Like, how do we like look across all these efforts? Because the health department, like somebody said, can't do it alone. So how does the health department work with other agencies beyond the city, other government agencies, the county, or even like the state, to say, listen, this is the number. And I think like we see data like this all the time. It's just like, okay, how much more money are we going to put into telling us what we already know? When are we going to invest money and resources into what do we do about what we know? So I guess that's my question. It's like, what is there a plan? Because I didn't see if there's a plan to work across city agencies, from CDPH to the Chicago Police Department to whatever other department that needs to collaborate, and then even at the county level, right? So from the state's attorney's office to all of these different departments that make up what these numbers look like. So is there an effort to work across agencies and to work across governments to say, listen, this is what the numbers are. What can you do? How can we help change these factors? Or will they just kind of continue to be like a research effort to say, well, this is what's happening. We don't know what to do, but this is what's happening.
Thank you. That's a good question.
I'm Danny, by the way.
Yeah. So as an epidemiologist, I won't be able to speak to all of that. I'm kind of providing the data so that the more action-oriented, like wants to be in the front of the group people can consider it in justifying the programming. But I would say that with all of these indicators, and it's certainly my hope for the life expectancy data, which I've been leading that analysis on, that all of our CDPH programs and all of our partners have access to that, can customize it to understand how health conditions that they may be focused on, may be experts on, are contributing to the gap so that they can use that to justify funding and investment. That's kind of my hope for where the life expectancy analysis will go and how we'll be helping people throughout CDPH and our partners. Some of the data that we've shared does come to us from other city and state agencies, and we're pursuing more. So, for example, the opioid surveillance data comes to us from emergency medical services, and we're actively working on getting more programs in CDPH to be able to have open access to that data so that we can track other health conditions or other situations that are disproportionately harming Black people in Chicago. Or did I? Yeah, it's me. It's user error. So, for example, my program, Chronic Disease, is trying to get information about how often CPR is attempted around Chicago communities, and if there are disparities in who's being saved by bystander CPR. We know we have research data that there's racial inequities in who even has someone attempt to save their life using CPR. And we want to know if that's happening in Chicago so that we can directly provide training to people where we know they're in a position to save a life. With regard to some of the other topics that you raised, I was thinking, as Brianna was sharing that information about opioid overdose, for example, Chicago is not an island. We're subject to, unfortunately, trends in health conditions that are bigger than our city, bigger than our county or our state, and yet it affects us and our neighbors, and it's our responsibility to help one another anyway. I'm very excited about some of the related work that we are doing to enact health equity in all policies across city government, for example. I think that goes even beyond partnership to saying we have enough information. We want to continue to track racial disparities and any type of disparity that's affecting Chicagoans, and we don't need to reinvent the wheel every time we consider a new policy. We need to start from the fact that racism is killing Chicagoans.
Thanks, Emma. And I actually want to just add a couple of things. The Healthy Chicago Survey, which is of Chicago, I understand that Cook County is also starting a survey using the same questions, so that we can kind of match up with the county and city data, so that we were getting it across a larger area. To the other city departments, every city department this past year, except for 3, did a racial equity action plan of specific commitments they're making. And I believe they built off of a lot of the data that's in the Chicago Health Atlas, and so that's some of what the other group is talking about. They're all on the Mayor's Office of Equity and Racial Justice website, so you can definitely check that out as well for kind of how departments are working together and committing to steps to address the racial inequities in Chicago. And the third thing I want to mention, just because the program I directly work with is the Healthy Chicago Equity Zones we presented earlier. So those are community organizations throughout the city who did their own community health assessment and got to work with even some of our epidemiologists, and Emma was at our daily office hours, as was Dan, to kind of get introduced to how to use the Chicago Health Atlas, right? It's only as good as people actually being able to use it. And so these were Black and brown-led organizations on the ground, being able to bring, so when they knock on someone's door, they can say, the current vaccine rates are this, and this is why this matters. Or, we know our community has more diabetes rates than in other neighborhoods, and that's why we should fight for a grocery store. So they come armed with that data, and so we've just started that work, but we're really working to get the data into the hands of community. Do we have other questions? Yeah.
Thank you. So as a user of Chicago Health Atlas, I applaud all that you have done. I know that was a lot of work. And I've noticed that it's been updated lately because I'm now seeing data for 2021 in some categories. The one category, though, that still seems to lag behind is maternal health. So I was wondering, number one, if you could speak to that. And then number two, communities are so hyper-local that some areas are doing well and other areas are not. So I work in Rogers Park, and that's a truism over there. So I'm wondering, how can you drill down into the data that's available to be able to know, well, this census tract has more inequity and we should focus on that census tract versus another census tract?
So with maternal health data, So we do hope to have those maternal and child health indicators more up to date and updated in a more timely manner in the future. It is something we're aware of. For hyperlocal data, our best source continues to be the Chicago Health Atlas. The Atlas, the Health in Chicago survey. They have such similar names. That survey actually was redesigned in 2020 in order to help us continue to collect local data. So previously that was a phone survey. Over time, fewer and fewer people want to answer their phones. So we redesigned it in order to make people invitations to participate in the survey. And we also use that approach to ensure that we're surveying enough people from every single community area across the city. So it should actually improve our data quality for each community area going forward. And the way the survey is designed now, we get enough data from every community area to update health statistics for that neighborhood every 2 years. At the census tract level, I'll be honest, we do not survey people at a high enough rate to release census tract level statistics. But we do supplement our data, including on the Atlas, with information from the census and from other census surveys like the American Community Survey. And that often is available at lower levels. And that also kind of motivates some of our interest in alternative data sources like the emergency medical services. We're always looking for, now that we have increased people's expectations of how local and fast-paced data can be during the pandemic, what can we offer people now related to other conditions in community health that feels as local and as timely while respecting the privacy of Chicagoans. So, more to come.
We have another question, and we're just letting know we have a couple extra minutes in this room. The main room's going to run over, so we've got about till 2:05. Any questions?
Well,
Yeah.
I guess piggybacking a little bit off that question, I'm curious how much, and maybe if using census data, not too much, but how much we're able to disaggregate these broad racial and ethnic categories, recognizing that these are heterogeneous categories that represent, a wide variety of backgrounds and experiences.
You can go and I can go.
That's something we talk about a lot as epidemiologists within CDPH. We're aware that multiple of these racial or ethnic groups are a lot more diverse than we're sharing. One of the benefits of aggregating people into, 3 to 5 racial or ethnic groups is they're really big then, and we can generalize about statistics that we're pretty confident in, but we lose a lot of that diversity within the group. So that's one reason we're motivated to continue to put out reports about the health of specific racial or ethnic groups, where we can give them the attention they deserve and incorporate, even if it's just like narrative, contextual information about who those groups are and what their health needs are. It's also something that we're considering when we seek out alternative data sources. So like as we try to better integrate with health systems and use like digital health record data for public health surveillance, one of our goals in doing that is ultimately to be able to disaggregate some of those racial categories and provide people more detail about their health.
I would say that Emma is totally right. Like, we are aware that these other categories exist, which is why we're trying to do a good job of capturing that on the Healthy Chicago survey. Every year, there's a steering committee to look at the questions that were asked, to make modifications if need to, and in recent years, we've been starting to collect more of that data that you see. I would say nationally that race and ethnic data is not collected always, or not collected well. And I think Chicago is a little bit ahead of the curve when it comes to making sure that we capture that data. It's also tricky to get that data with other data sources. So we do the best that we can to make sure that, you know, we're talking to community partners to figure out what we need to be collecting.
Okay, I'm gonna put you guys on the spot. If we have a second, yeah. Go for it.
Just one last question. Are we going to get the slides?
Yeah.
Yes?
Yes?
Okay.
So it'll just go out to everybody?
I think we'll figure out how to follow up with everyone who registered, and you got the information if you didn't register for the slides.
Okay.
And so the Chicago Health Atlas has been promoted a couple times. I'm not as much of a wizard with this as you guys are, but if you talk me through it, I can pull up like one or two of the highlights of the website. I can show you the parts I use, but I don't know, Emma, if you wanna, or?
Show life expectancy, actually.
Sure. So over here, in terms of the menu, one of the things, so like I said, I work with Healthy Chicago Equity Zones, so I work with the West region. I can kind of go in and specifically choose the West region, and I'll zoom in there. Let me go back out and start from the indicators. Life expectancy will be under mortality.
It should be. To be honest, I always just search.
Okay, the first two.
If you use the search indicators, like
Just up here.
down there, where's the search indicators?
Oh, here we go. Life expectancy. Yep, there we go.
You can also do like life expectancy.
So you can see this, it's generally broken out by community area initially. Will it change? Let's see if I can.
I think we just have community area, but yeah, if you go to places on the right in the world,
This one.
and
So do you want me to pull up something specific?
Regression.
Okay, yeah. Whatever. Someone called out Auburn Gresham, but we might want to zoom out a little. Here, let me do an equity zone.
I also want to say we have Dan Palato in the office, in the room, who is an epidemiologist in the Office of Epi. And every other week, Dan hosts the All Atlas user group trainings. So he's very knowledgeable about the Health Atlas.
Yeah, we can help.
Sure, do you want to come up and pull up a couple of things? Okay, sounds good. This is the bonus part of
Okay, I don't even know what we're doing. So, I guess we're on life expectancy. So Nicole did a great job of finding a community area. West. No.
It's the West region.
It's the whole region. Yeah. Yeah. So this is Health Equity Zone, and obviously if you hover over it, you can see the estimate on life expectancy. Well, in Chicago and in the West region right here. This is the map version if you want to see like comparisons and trends or just like a trend line, or bar graphs. It's separated by strata here. All these different toggles, as Mary, you mentioned recently, the Health Atlas had gone over some updates. So you might need to, if you had used the Health Atlas prior to this, you might need to kind of hover over some of these indicators to see what they actually do. But if you want to go different chart view, you can go from like over time through looking at one strata or multiple strata, as we see here. So if you want to go for multiple racial or ethnic categories over time, you can see how life expectancy has changed within each one of those strata. If you just want to see the most recent data, just what we had here for 2020, coming out with multiple New Year's forward, obviously. And then don't be afraid to like toggle around different places. You can go through. Typically, it's like one or the other because of the reasons that our epidemiologist said before. We want to protect the privacy of some of the individuals of lesser representative categories. So if it's by community area and females and non-Hispanic Black, it's going down to the nitty gritty. It might be too small to show. Plus, if we have a very low representative, oh, it wasn't just you, it was just, it cuts out sometimes. If we have a large disparity between a couple groups and our map that looked nice and pretty, like, no, I guess. Something like that, yeah. We had a nice, pretty map. Oops, yes. If we have a nice, pretty map like this, sometimes if there's a big gap between the underlying population of a certain indicator or a certain strata, that this map might look a lot less populated, and you might be thinking, well, what's the government hiding from me, or why can't I see all this data? And the reason is we just don't have enough respondents or data to show accurately and confidently with that information. So, we choose to put the ones that we are most confident in, that are best representative of what we do know with the data that we have. Another thing that I want to just quickly point out is these tabs over here. I believe Megan earlier this morning had mentioned, or I think there was a hyperlink on the slide, the We Build dashboard for racial disparities here. We have a new mayoral initiative for this We Will Chicago. All these different, it's kind of broken down the same way that Healthy Chicago 2025 is. We have different pillars across different city departments and bureaus, and you can toggle between what indicators are we looking at for lifelong learning, how is that different between different racial and ethnic categories, and you can explore more about some of the indicators over on these icons here. This is a living document, so we will have more information going forward. Lastly, we also have, I think, Chicago 2025 that had been updated just last night. There's information. It's almost like we were having a symposium today. So a lot of the information that you had seen today with Emma and Brianna will be here, but the slides will also be helpful as well.
Great, thank you, Dan. Appreciate you being willing to jump in. I swear I've used it before, I was just like, about how to do it. But yeah, just really want to thank you all for joining us in this breakout room. Just want to give you a quick lay of the land. We will have some folks to help walk you back to the main room. I know we're on two sides of the building. I would recommend using the bathrooms like on the first floor and or back on the other side, because they're kind of confusing to get to here. Yeah, so we're going to get started in the main room about 2:15, maybe a little bit after, to do a little wrap up. And I have an announcement from my colleague.
Yes. Yeah. We also are asking people to do a share out for each room, so we need a representative from this room to share out some of the things we talked about. And I just walked in here, so I don't know.
Thanks. Is anyone excited to do it? If not, I think we did talk to our presenters about doing it.
Great.
Okay.